in Delhi, and I'm going to give you a very low-tech 2D presentation compared to the 3D that you're all here for. And just hang in for about 10-15 minutes, and then you can get your course started as well. So I've been asked to give a little insight into what's been happening in the past, what we are doing currently at this point of time, and what we are headed towards in the realms of orbital surgery. But keeping in mind that past, present, and future are relative terms, some of us are still stuck in the past, some of us are in the future already, and so this is going to be addressing a lot of the entire audience to talk about what we're doing in orbital surgery. Orbital surgery has got lots of fun things to do. It is challenging, and that's the reason why the average ophthalmologist dreads going inside the orbit. But yet it's quite rewarding because we make life-changing decisions for these patients as well. Provided you have good, sound, basic principles and techniques and approaches to diseases, more often than not it's rewarding than it's disastrous as well. The reason why we are able to do so much today is partly because, yes, we are evolving into wonderful and better surgeons, but most importantly because of significant leaps and bounds and advances in technology, in bioengineering and technology, and we are now adapting new techniques and technology into our surgical techniques, which is the reason why we are able to now touch cases which otherwise in the past was quote-unquote best left alone. So I'll touch base a little bit about the evolution of orbital surgery, who did the major contributions. We'll talk about what are the newer technologies which are coming right now at this point of time, its applications in some of the complex orbital reconstructions, which again we dread because we don't have conceptual approaches. And finally, I'll touch base a little bit about what's new on orbital oncology in this presentation. There's a famous saying that the war is the best school for a proper trauma surgeon. And that's the reason why every single potential traumatic case that comes to your institution, private practice or institution otherwise, is the learning ground to prepare your residents. And I sometimes feel bad when the trauma pictures, Harold Gilport is the father of plastic surgery. I'll touch a little bit about it. And if you're doing a lot of these osteotomies and craniotomies for complex orbital reconstructions, it's Paul Tessier who we should all be recognizing and acknowledging. Now, of course, every single time I touch the orbit, I do not think about Professor Jack Rootman, who has actually made major contributions into our diseases, understanding pathogenesis and management. So this guy was a loony guy. He was a French general surgeon. What he did was he abused cadaveric heads. This is talking about experimentation in surgery, and then he prepared these bony specimens, and then finally he came up with a classification system called the Lefort fractures, as you can see over here, where we are talking about a type 1, type 2, and a type 3. Type 3 is where you have a complete craniofacial disjunction. There's a complete transection right from the lateral orbital rim, medial orbital rim, the NOE, and finally the lateral orbital rim on that side. That's a type 3 Lefort fractures. And he basically came up with the concept of the orbital struts, the facial struts and the buttresses, which are the principles behind which when we try to refixate these faces and the orbital facial skeleton, if you do not fixate these buttresses, you're not able to do a good job of it. We all are familiar with the blowout fractures, but in our practice it only forms about 10 to 15% of all the orbital fractures. Remaining 75 to 80% of various combinations of these fractures, and those principles that we learned from Lefort's classification is what we do for our facial fractures. The second big name you should be aware of is this New Zealander called Harold Gillies. Some of you are familiar with the Gillies approach to zygomatic fracture reduction using Gillies small incision right over there. But he's the one who actually introduced a lot of facial flaps and reconstructions and various forms of orbital approaches as well. And what he first time defined that cosmetic surgery is nothing but an extension of your reconstructive surgery. So those of you who are aspiring to be aesthetic surgeons, you want to be good reconstructive surgeons first and then apply these techniques in the real normal patient. The third big name I want to mention about is Paul Tessier. He came up with the famous clock face classification of craniofacial deformities, but he's also the first one who described the various osteotomies to treat complex conditions like these. If you look at this gentleman, he was an avid researcher. At his time, he was shot down, and even his papers were rejected by major English written journals because they were so outlandish at that point of time. He had to publish them in a French journal. And only after the rest of the world started adopting these techniques into wonderful surgical outcomes that they started publishing in the English-speaking journals. The classic examples are patients like these who have various forms of craniofacial dysostosis, which again we as ophthalmologists or orbital surgeons do not touch. But here's an example of a patient where what we have done is done an osteotomy, we have done a front orbital advancement, we've done a midfacial advancement, and notice that osteotomy right over there, extension of a bone graft and a screw over here. So basically through a coronal approach, you've done an osteotomy here. Through a midfacial approach, you've done an osteotomy here. You advance the superior part of the roof of the orbit, you advance the inferior part of the middle face of the orbit, and then you have a patient like this where you are actually reduced not the proptosis but the exorbitism, and reduce the projection, so that with a little bit of other slight enhancement, you can do that. That's what has been given to us by this as well. And of course, no talk in orbital surgery is complete without Professor Jack Rootman, to whom I owe all of what I do in orbital surgery itself. So what are the challenges in orbital surgery? The problem is expertise and training. Not very many centers train our orbital surgeons very well. Everything that you do in terms of surgical management is related to preoperative diagnosis outcomes. It's important that you're aware of the danger zones of the face, and finally understand the concept that when you put your structure back together, the function usually recovers as well. The concept of structure-patient relationship. So what's new in orbital surgery? There we are going into small and small incisions. We're going to multimodality management. In the past, we used to take big pride in doing big incision surgeries, but now finally they're all small incision surgeries. And we are now even coming to pinpoint or pinprick surgeries, and I'll showcase some examples. And these are the things which are making it possible for the leaps and bounds and advances we do in orbital surgery. So one of the major applications that we do is navigation surgery. It's the same thing that the drone technology used for GPS, where we have real-time intraoperative navigation of various locations and danger zones of the orbit as well. So if you look at translation of what is anatomy over here, you're able to now look at it on a CT scan, which is on the screen right by your side in the operating surgery room, so that at any point of time, you put your Freer elevator, you put your implant, you put your whatever inside the orbit, the danger zones, typically the inside of the orbit, you should be able to see it on the screen. So this is not only a tool for beginners, but it's a tool for advanced surgeons who are starting to touch areas of the orbit which you are not able to touch anymore. And with a combination of intraoperative navigation, we are now using endoscopic orbital surgeries. The traditional endoscopic orbital surgery was all transnasal, but now we are doing direct transorbital endoscopic surgery. So we are now combining endoscopic and navigational surgery and delivering much, much better results. Now removing tumors right at the apex of the orbit, which otherwise we will not be able to do that. The second major advance in the realm of orbital surgery is orbital implants. We all know about anophthalmic socket implants, but I'm going to touch a little bit about orbital facial fracture implants. And there are numerous implant options available. But what are the two important things which are important is the concept of this anatomical prefabricated plates. These are special plates which are three-dimensional plates, have a curvature to it, has got a floor component and the medial wall to it as well. So when you see there's a rare combined floor and medial wall fractures, which otherwise we have difficulty fixating both the floor and the medial wall at the same time, these come in handy. And of course the applications of bioresorbable implants. So here's an example of a patient who's had surgery once or twice elsewhere, came up with a residual deformity, and remember, see how beautifully we reconstructed the floor of the orbit exactly to the angle on the other side. So concept of the angle of the orbital structure which you defined. And more important than the reconstruction of the floor and the medial wall, notice the convexity we have now given to the floor of the orbit, which gives you the anterior-posterior projection, and thus minimizing the risk of enophthalmos of these patients as well. So orbital surgery or orbital fracture repair is not a matter of just opening the orbit and sticking an implant inside. We see that all the time. It's accurate reduction and perfect correction and restoring the original orbital anatomy, which was there pre-morbid or pre-trauma situation. The second situation is the use of bioresorbable implants. If I gave you the CT scan of the orbit, you would look at it and say what's going on right over here, right? So, but if you look at it, what he had was a large orbital fracture where there's been a floor dissection and a bioresorbable implant inside. And the bioresorbable implant goes away in about 18 months, by which a fibrous scaffold and the existing osteocytes which are over there start doing the healing process. So eventually you get a situation where orbit looks like normal, restores to its normal condition, pre-morbid condition, with the implant no longer be there. So you no longer have to put in implants in certain cases which have to be there for the rest of the life, which can potentially give complications as well. So the current concepts in orbital fracture repairs, I use bioresorbables generally in all pediatric and certain adult fractures. I use a Medpor implant or a porous polypropylene implant. I don't have any financial interest on these, on large blower fractures, but more and more when you start doing very complex fractures, I generally tend to use a prefabricated anatomical plate for both the floor and the medial wall fractures. What else is new in orbital reconstruction? We are in the era of 3D printing. We now know there are even houses and apartments, cars, which are being built on a 3D model concept. That's basically a 3D model which comes out in about 2 to 4 hours based on the preoperative CT scan. And we use it for various indications as well. This is a child who came to us with a significant proptosis, frontal bossing. You can see the crowding at the apex of the orbit, completely involving the optic canal over there. Again, a case which normally we would not have done. We are now able to do simulated virtual surgery outside the real space. We are able to carve out the pathological bone tumor that you're going to be removing. So even before you touch the patient, you have an idea of what the defect is going to look like at the end of your surgery, provided you're able to deliver that. And then depending on what kind of reconstruction you're going to do, whether you do a patient-specific implant or a normal implant, you basically completely carve out what you have preoperatively, completely take out the tumor, you're doing an optic canal decompression, and the entire tumor is out, following which you do a reconstruction. So we are using these kind of concepts for complex orbital fractures. There's a lady, motorcyclist, pillion rider, came to us with a panfacial deformity, anophthalmic contracted socket, soft tissue stuck down. Again, has had multiple surgeries elsewhere, where through sequential planning and meticulous surgical technique, we're able to now restore her to normal life, so that even though she's still blind wearing a prosthesis, she has a better appearance than what she was before, and she's not just physically rehabilitated, but psychologically rehabilitated. The fourth thing that I'm going to touch about is the concept of pinpoint surgery, and that's the point I'm talking about. So you're not even talking about incisions anymore. This is a child who's had strabismus surgery twice, failed, residual strabismus, and what she has is a vascular malformation. So we have made lots of changes in vascular surgery, whereby we are now using percutaneous interventional techniques to outline and map the lesion. We are doing now intralesion sclerosing therapies, whereby at the end of the sclerosing therapies, without any surgical downtime and any significant bleeding and mortality, we are able to reduce the total amount of proptosis that's present. This is another child who is referred to us from Bangalore, who actually we've done again one cycle of intralesional sclerotherapy with, you can compare reduction of the intraorbital vascular lesion, which otherwise will not have been surgically operable as well. So what's HOT in orbital surgery? HOT stands for a hybrid operating theater, where you have real-time intraoperative radiological guidance to what you're doing as well. So this, we work very closely with our interventional radiologist. This is a lady who came to us with bilateral keratoco-cavernous fistula with multiple morbidities, congestive cardiac failure, renal failure. They've tried the percutaneous femoral approach, all failed. Then we opened up the orbit over here, identified the superior or the medial ophthalmic vein, put a catheter inside. And using that catheter, we are now able to gain access into the cavernous sinus, through which your interventional radiologist is able to go and coil the cavernous sinus. So once again, an orbital surgeon gaining access to the brain, whereby the interventional radiologist is, so that we are able to restore her to normal vision as well. The last thing I'm going to touch about is the concept of in orbital tumors. Exenteration was a procedure we hated to do. At the same time, we love to do because of the rarity and the bloodiness of the surgery itself. But we now know that in a lot of conditions, exenteration has no role, because patient still dies, has significant morbidity and mortality even after you do an exenteration as well. So a classic example is patients like these who are treated initially as orbital cellulitis, eventually diagnosed as rhabdomyosarcoma. Now with the combination of chemotherapy and radiation, we're able to not only keep their eye as it was, except for a minor residual deformity, including loss of eyebrow hair, a little bit of superior sulcus deformity. These are living survivors, and the only complication they may have is a radiation-induced cataract, which can be treated. This is a patient who actually required an orbital exenteration because of an invasive lacrimal sac carcinoma. We fought hard with the ENT and the maxillofacial surgeons to keep the eyeball in, where we have done a medial maxillectomy floor and a medial orbitectomy, complete resection of the medial wall of the maxilla, and with good reconstruction. Here is the same patient 5 years later, keeping the eye without anything at all. 2 minutes. Okay, so here's another patient who's done as well. So what is new in orbital surgery is multi-modality, multidisciplinary management, and we have to start working as well. So the future is, number one, there are patient-specific implants which are going to be useful. We are now starting to use virtual reality surgery. This is a demonstration of concept where you can have the real surgeon in the operating theater, and you as an experienced person can be staying inside the room using technology, where we are actually using a traditional iPhone and iPad or whatever it is, that surgeon operating somewhere in the operating room having some difficulty, you're guiding them and telling them that by rotating the skull over here, look at the fracture over here, try to fixate the fracture, and you're intraoperatively guiding them while you're sitting in your room elsewhere as well. Robotic surgery is coming in a big way, and we are starting to use it more and more for head and neck and skull-based surgeries as well. The more problem we have is that you have the remote access and at least about 10 feet distancing. Now with the introduction of 5G technology, which is going to be the standard of care by 2020, it's just about 100 times faster. We are now able to transfer that skills from the robotic bimanual surgery to the surgery on the smaller incisions. I think orbital surgery lends itself to lots of adaptations and innovations. We are able to do far more with the orbital surgery and adaptation of modern techniques. I enthuse the younger generation to take us even higher than where we have gone before. So thank you very much, and thanks for giving me the time.